We are about to start, and thanks for joining our regular monthly LabCoP session for May. Traditionally, these have been mostly HIV and TB focused, but as you realize, we have an emergence with us, and we want to speak how we are leveraging what we have to do that. Just like our tradition, today we have our colleagues from Kenya, from the Kenya LabCoP team, who will be facilitating the session today. And allow me to hand over to our session moderator, Oma. Kenneth, over to you.
Thank you, Anafi, and welcome. My name is Kenneth Ndiege, strengthening and under collaboration between the National Public Health Laboratories and the University of Maryland, funded by CC. As Anafi, I'll be your moderator today. In the fight of the COVID-19 pandemic, it is important that we improve access to testing, leveraging on the existing infrastructure and capacity. And today we are focusing on key considerations on expanding COVID-19 PCR diagnostic capacity in laboratory retired network to enhance access and meet demand for testing with a case experience from Ethiopia. This will be a 1-hour session, and we'll have 2 presentations followed by question and answer segment. All participants are reminded to share questions and comments on the chat box. We have lined up 2 experienced presenters, Dr. Margaret Masinga Lombe, a Senior Laboratory Advisor, Africa CDC ASLM, and Resolve to Save Lives Project, and Mr. Adisu Kabede, Director and National Laboratory Capacity Building Directorate, Ethiopian Public Health Laboratories. I'm going to hand over to Dr. Margaret to take us through the first presentation. Over to you, Dr. Margaret.
Thank you, Kenneth. So let me share my screen.
Hi, Adisu, can you hear me now?
Hear me?
Perfect. Yeah, I can hear you now. Just quickly try to share your screen, the title page. Hi, everyone. We are about to start. We just want to make sure the second presenter is ready. Then we start. Adisu?
Yes.
Okay, can you try and share your screen quickly? Just the front page will be fine.
Can you see it?
Yes, try to put in presentation mode. Perfect. All right, thanks.
Okay.
Yeah, you can stop.
Okay.
Hi, everyone. We are about to start, and thanks for joining our regular monthly LabCoP session for May. Traditionally, these have been mostly HIV and TB focused, but as you realize, we have an emergence with us, and we want to speak how we are leveraging what we have to do that. Just like our tradition, today we have our colleagues from Kenya, from the Kenya LabCoP team, who will be facilitating the session today. And allow me to hand over to our session moderator, OMA. Kenneth, over to you.
Thank you, Anafi, and welcome. My name is Kenneth Ndiege, strengthening and under collaboration between the National Public Health Laboratories and the University of Maryland, funded by CC. As Anafi, I'll be your moderator today. In the fight of the COVID-19 pandemic, it is important that we improve access to testing, leveraging on the existing infrastructure and capacity. And today we are focusing on key considerations on expanding COVID-19 PCR diagnostic capacity in laboratory retired network to enhance access and meet demand for testing with a case experience from Ethiopia. This will be a 1-hour session, and we'll have 2 presentations followed by question and answer segment. All participants are reminded to share questions and comments on the chat box. We have lined up 2 experienced presenters, Dr. Margaret Masinga Lombe, a Senior Laboratory Advisor, Africa CDC ASLM, and a Resolve to Save Lives project, and Mr. Adisu Kabede, Director and National Laboratory Capacity Building Directorate, Ethiopian Public Health Laboratories. I'm going to hand over to Dr. Margaret to take us through the first presentation. Over to you, Dr. Margaret.
Thank you, Kenneth. So let me share my screen first. So can you all see the screen?
Yes, we can see it. Thanks.
Okay, thanks. Okay, so thank you and hi everyone. Thanks for having me as a presenter on this LabCoP session. So it will be my pleasure to discuss with you, present to you the key consideration for expanding COVID-19 diagnostic capacity at the subnational level and answer any questions you might have pertaining to that topic. So as we are speaking today, the COVID-19 pandemic has reached the African continent and is spreading across the continent. So as of today, according to the Africa CDC dashboard, we are almost reaching now 100,000 cases, confirmed cases on the continent. As part of the strategy to really limit transmission of the disease, what is being proposed is the tests isolate, find or trace the contact and quarantine all contacts in the community. And so henceforth, laboratory diagnostic is really the cornerstone of this strategy. That's your starting point to be able to identify and isolate the cases. The diagnostic capacity on the continent was quite limited when the outbreak started. So we had 2 laboratories at the continental level, but then through efforts to ramp up the capacity, the volume of testing has increased. And today we are reaching almost 2 million diagnostic tests performed in Africa. However, if we look at the total estimated testing capacity on the continent, this is only a fraction of what can be achieved, because putting together the capacity in the public sector, the private sector, and the animal health sector, we could be testing as much as 40 million volume to test 10 million people in the next 6 months, to really have a more accurate idea of the spread of the disease on the continent, as it has now transitioned into community-based transmission, and also to be able to identify the cases promptly and isolate them and limit the transmission, as I was saying. And after the meeting of the Minister of Health in Addis Abeba, countries, head of state agreed and approved the African Joint Continental Strategy for COVID-19 outbreak. And as I was saying, thanks to the effort undertaken under that strategy, Africa has been able to ramp up capacity, first of all, at the regional level, starting from the two WHO reference laboratories in the Institut Pasteur in Dakar, in Senegal, and the NICD lab in Johannesburg, in South Africa. And that was increased to 43 labs, all able to test, having capacity for COVID-19 diagnostic across the continent. This was also sustained by effort as far as supply chain were concerned. And so 1.5 million laboratory tests and IPC supplies were provided, notably through the Jack Ma Foundation. But now, if we want to go really higher and reach that stage of 10 million tests in the next 6 months and 40 million tests altogether, we need to continue the expansion, and we need to go downstream now. And the next stage would be to really achieve national scale-up. So scale up the testing capacity at the national level, starting from the top of the healthcare pyramid, so where those national public health laboratory or center of excellence, where the capacity has been put in place now, thanks to Africa CDC, WHO, and also WAHO. So that was the starting point. And how can we now cascade this down through the different tier of the healthcare pyramid? That's our goal, that's our objective. And so I will be discussing with you the key steps and the key elements that we need to take into consideration now. So the first key element is the one of good governance and coordination at the central level. So coordination, which would be led by the Ministry of Health and with all the different actors on the ground. And so you need to have a multi-sectoral approach, really, to include all the key stakeholders, which can play a role in the response to COVID-19, which might have expertise pre-established in place and which can have the know-how to perform at least molecular testing, because the current reference testing method for COVID-19 is RT-PCR, real-time PCR. That's a complex technique, and it demands skilled staff. And so you aim to really go where the expertise is already in place. And so you could include the private sector and the academia. The disease control program also have a lot of experience in ramping up testing capacity. And so the TB control program, the HIV control program can be approached. And even the vaccine program can be approached because they do have a lot of expertise also in specimen transportation. The animal health sector, and the military sector are also key stakeholders. The animal health sector have expertise in diagnostic of zoonosis, and so they might have pre-established expertise also for molecular diagnostics. And of course, you need your key technical partners and donors, which are involved in supporting development of laboratory network and system in the countries. The aim is really to achieve coordination among all the actors and avoid duplication of tasks and duplication of intervention, and achieve synergy. And the idea is, because we are in a context of public health emergency and also limited resources, because it's a pandemic, it's affecting the whole planet, and resources are few, as we've seen, shortages. So the idea is really to see what do we have already, and how can we leverage on what is already in place to really ramp up testing capacity efficiently with the minimum of input needed. And once all those people have sat together and discussed, the idea is to come up with a scale-up roadmap with really clear targets and timelines as to how the diagnostic capacity can be expanded nationally. So the consideration you will have, as I'm saying, you are not reinventing the wheel. You are not starting from scratch. You aim to start with what is already in place. So you might need to determine the infrastructure which is needed for PCR molecular testing. And so you will look at the equipment footprint, because you might have conventional RT-PCR. There is a P missing there, sorry. And also now, more and more under emergency listing, you can be using also high throughput platform or automated platforms such as the Abbott, and the Gene Expert, etc. And as I was saying, you will see also what is your capacity in place for a specimen transport network. And so this existing capacity will inform and will be used to fulfill the needs. So what are the needs for expanding the diagnostic capacity in terms of geographic coverage? Because we are aiming to achieve access to COVID-19 diagnostic services for everyone and everywhere in the country. Everyone should have access to testing if they are in need of testing. The testing volume and also the testing algorithm. So we are talking of the healthcare pyramid. We need to determine what type of test will be done. Is it specialized reference RT-PCR, or do you want to go for point of care or near point of care testing, and at which level of your healthcare pyramid? And for whom? Who will be the targeted population? Who will be the people that you will be prioritizing for testing? And so with that in mind, you will be coming up with testing strategies. So if we take the example, for example, the example of Nigeria. Nigeria has taken the time with the support of the technical partners and all the actors on the ground. So the Nigeria Center for Disease Control managed to come up with a national strategy to scale up access to COVID-19 diagnostic in the country. So Nigeria is a big country with very many states. So they are opting to really increase the number of molecular laboratory in the country. So they want to increase that network. And so they started by looking at the existing capacity laboratory, molecular biology laboratory in the network. And so they are aiming to increase from 9 to 15 laboratory. But as I was saying, they're also looking in the pre-existing capacity in the HIV testing laboratory network using the high throughput platform. And then they're also leveraging on the Gene Expert machine to be used for COVID-19 testing. And as of mid-May 2020, they have now expanded and achieved 26 new laboratory in place and operational for COVID-19 testing. So that's one option for a very big country with a large outreach needed for geographic coverage. You might have also other options. For example, for smaller countries, you might not need to increase the number of laboratory per se. You can rely on the initial reference laboratory which has been put in place, and then expand the outreach of your specimen transport system. And there are many ways to do this. So as I was saying, you can leverage on those which are in place for vaccine prevention, the polio and the measles specimen transport network, also HIV and TB specimen transport system. So here we have the example of a centralized specimen transport system where you have hubs at the periphery level, which are referring to the intermediate level, and that intermediate level they are referring to the central lab. And there are also ways to be innovative. So for example, in Ghana currently, more than 1,000 health facilities are referring those samples for testing using drones. And this is really an innovative way to really increase the outreach of your specimen referral network. So this is an option which could be useful for smaller countries, and the sites that you can use to put in place capacity for either RT-PCR or, as I've said, point of care or near point of care testing. And so if you have evidence base already available, you will be looking at that evidence base. So example of evidence base is the ASLM lab map data, whereby pre-existing capacity and capabilities in the national lab networks have been mapped. And so just using the database, you can really access rapidly to information pertaining to pre-existing infrastructure, equipment, and human resources. And you can even have information pertaining to biosafety. So if we're talking of RT-PCR, you need to have biosafety level 2 in place. So it means you need to have a biosafety cabinet. And now with the most recent WHO recommendation, which were released on the 13th of May, we know that for point of care or near point of care, for example, if you're using the Gene Expert, you might not need to have a biosafety cabinet in place. So these are the criteria that you will use to really do a pre-selection of the site and then assess to see if all the elements are in place. You will also take into consideration the proximity between your future testing site and treatment center, or you might want also to increase the capacity in specific transmission hotspots within the country. So if you don't have that pre-existing data, you can also rely on the WHO assessment tool for COVID-19 laboratories. So it's a control list, a checklist, and that can be used. And so either you have to go on the ground and see what is in place. But with the current context where you have lockdowns and limited movement in the country, there is also the option to have this done remotely by the team, which is on location, and they can just cross-check the different elements that are needed. And one also element which is really, really important is the one of free testing capacity. If you're planning to repurpose, take advantage of TB or HIV testing equipment. So we're talking of the Gene Expert or we're talking of the high throughput instrument. These ones are already in place, and they're in place because they are used for testing for those essential diseases. And you don't want to divert all the resources towards COVID-19 testing. So as a starting point, you will first determine what is the free testing capacity. So at a given location, you might have a Gene Expert machine instrument, which is only used at 50% of its capacity. Henceforth, you have 50% that can be dedicated to COVID-19 testing. So with that in mind, there are different recommendations which have been published and released by WHO and for the Stop TB Partnership that you can have a look at, because they are giving you guidelines as to how to ensure maintenance of essential testing services for non-COVID diseases. During the Ebola outbreak in Western Africa, it's been demonstrated how really the capacity for other diseases, everything that was in place was really, how should I say, crashed down because of the Ebola epidemic, as all the resources were diverted towards Ebola. And if you do not address this point, you will really have a scale back of all the progress which has been achieved for those diseases. Once you've done the assessment, so you select the sites that you will be using, and you need to prepare those now for routine COVID-19 diagnostic. And so what is necessary for a site to be operational? First of all, you need to have clear guidance, national guidance for COVID-19 testing. You need to have a testing algorithm, you have to have testing protocol, and you need also to provide the documentation, SOPs, register. So you need SOPs for specimen collection, SOP for testing, SOP for waste management, etc. You need to have those in place. You might have a need to upgrade your equipment as well. So we're talking of the Gene Expert equipment, the instrument. You will need to have maybe a software upgrade. It depends on what type of instrument you have and how recent it is. So you need to keep this in mind, because resources will be needed and support will be needed also for that to be done prior to initiate COVID-19 testing. You need to train the staff and assess them for competency. So you need maybe that's the idea of leveraging on pre-existing capacity. If you select site within, for example, the animal health sector, or even in the private sector or the academia, where people are already trained on molecular biology, then the training needs will be minimal. They will need only to be trained on the testing protocol per se, but they will already be familiar with all the processes pertaining to molecular testing. Likewise, if you're training staff which are used to the gene expert, they will need to be introduced to the new testing cartridge, but the processes will be similar. Henceforth, your need for training will not be as extensive. And one element which is really key and that we should not forget is the forecasting the supply chain. Where will you need reagent and consumable, and how much of it will you need? And in the current context of limited resources, where Africa has to fight with Western and countries or countries in Asia for access to resources, this is really a key consideration. So there are two main initiatives currently underway. So I mentioned the PACT initiative by Africa CDC and the African Union, which is aiming to increase testing volume and is also offering pathways for pooled procurement at the continental level. So all the African countries are coming together with their needs, and that centralized procurement system will enable the purchasing, because it's increasing the ordering volume and equitable distribution. And likewise for the WHO-led, it's a multi-agency initiative, which is called Access to COVID-19 Tools, so the ACT Accelerator, which aims also to ensure equitable access to COVID-19 intervention, diagnostics, and vaccines. And so these ones are enabling procurement at the central level. As you're expanding subnationally, the challenge will be to really get that central level procurement trickling down through the healthcare pyramid. So from that central level, you need to make sure that all the structure at the different level of the healthcare pyramid where COVID-19 capacity will be put in place can have access to uninterrupted supplies for testing. And the last stage, once your sites are operational, so you have everything in place and you start testing, you need to really have a close follow-up and monitoring in place for the new testing sites. You can define key performance indicators, notably the number of tests performed, the number of positive results. This will help inform the supply chain forecasting and procurement. It will also help really keeping an eye on the performance of the laboratory. You can have a look at the QC, how many QC filling do you have, quality control. So this is giving you a proxy of the quality in place at the level of those new sites. You need to organize supervision. This can be done on site, or as I was saying, because of the current context, you might have to use remote mentorship options. But you need to keep a close eye on the new testing site. As they are being set up, that's the startup period where you expect to have more issues coming up. And so these need to be addressed early, they need to be identified, and really corrective action should be put in place promptly to ensure a quality testing. And these lessons learned will also help you continue the expansion as time goes on. And finally, you want to ensure participation in the national EQA program. So the central reference lab, which have been capacitated with Africa CDC and WHO, will be, as part of the capacitation effort, will be enrolled into international EQA program, so PT, proficiency testing. But you don't want the EQA to remain at the central level only. Those central labs need also to provide EQA services to the new testing sites, which will be put in place. And one of the way to do that in a faster way, so to speak, and you might consider simplified options, such as retesting or rechecking, which can be done either through the supervision visit, if you can go on site, or with having samples being sent to the central level for retesting or rechecking. So as a summary, really, you have key stages for scaling up diagnostic capacity at the subnational level. So as we've said, there is the planning phase where you need to have a governance framework, an extension roadmap, and start already the processes for supply chain forecasting. And this is done and led by the Ministry of Health and a technical working group within the Ministry of Health, and at the interface of the COVID-19 response committee or the COVID-19 response team, depending on how it is organized in your respective countries. Once the planning has been done, you will move forth with selecting the testing site and assessing to see what is in place, what might be missing, are there any need for reinforcement, or can you start with what is already in place? And you will need to provide also the documentation. Once the site has been selected, you will move forward with the installation, either updating the new equipment, ensuring maintenance, and competency assessment of the staff to make sure that once the routine operations are in place, everything is should be available to ensure really quality ensured testing. And once the operations are ongoing, you will keep an eye on the new testing sites through supervision, through external quality assessment, and corrective action and retraining as required. And so all those steps from the selection, installation, and supervision, follow-up and monitoring stage can be done by the central reference lab in collaboration with the technical and financial partners on the ground. So this is what I wanted to present to you, and I thank you for your attention. Over.
Thank you, Marguerite. We'll now listen to a presentation from Mr. Adisu. Over to you, Adisu.
Okay, thank you very much. So this is Adisu from Ethiopian Public Health Institute. So I'll take you through Ethiopia's experience in expanding COVID-19 PCR diagnostic laboratories. So this is the outline of my presentation. I have background. I will take you through how laboratory expansion is happening in Ethiopia, how we are in testing. Quality assurance, specimen referral linkage, and challenges we have. So as a background, we have National Influenza Reference Laboratory, which is a pioneer laboratory in COVID testing in the country. Yes. So this laboratory is to conduct testing on influenza and other respiratory viruses, COVID-19, and arbovirus, and also hepatitis A and E.
This we are struggling.
So when we come to
Hello, Adisu, we cannot get you clearly. Hello, Adisu. Seems we've lost him. Mr. Adisu. Hello, Mr. Adisu.
Looks like we lost him. Maybe we can give a question.
So, can you hear me now? I'm sorry, we have unstable internet here.
Yes, we can hear you.
Okay. So we started COVID-19 testing through a referral service to South Africa, which was started on January 28th. And we then trained our professionals in Dakar and at EPHI. And then we started.
Kindly upload the slides.
Okay. Shall I go on?
Hello.
Hello, can you hear me now? Can you see my slide?
Mr. Disu?
Yes, yes. Can you hear me?
Yes, Mr. Adisu, we hear you. Please, you have 10 minutes to go through your presentation. Go ahead. Thank you.
Okay. Okay, thank you very much. So the National Reference Laboratory was the only laboratory in the country to conduct COVID testing until April 7th. So when we come to laboratory expansion, so the ever-increasing testing need couldn't be made by one national reference laboratory only. So our option was to go to increase the number of laboratories in the country. And this is our laboratory expansion process beginning. So this needs come through two ways. One is we identify laboratories in the country which have existing capacity. And the other thing is some few laboratories like universities and some research centers, they made a request to National Reference Laboratory. So we conducted assessment and helped them to continue to provide the service. So before coming to service, the laboratories are trained by National Reference Laboratory, and our National Reference Laboratory also provide those laboratories with SOPs, worksheets, different protocols. So once those laboratories are trained, we also conduct verification and before service commencement. So we send a team of experts from National Reference Laboratory to each site for instrument installation, biosafety cabinet certification and verification, and also on-site instrument verification and testing together with the laboratory. So as part of this process, we also conduct quality checks before the laboratory start the service, and confirmation of the first 10 and positives and negatives are conducted at National Reference Laboratory. So this is our national site readiness assessment checklist. We actually customized from WHO. So each laboratory is expected to fill this checklist on self-basis, and also our national laboratory team will also conduct and verify the information which is completed by each laboratory. So these are the components of the checklist. So we always check whether each laboratory has functional real-time PCR machine. It can be existing, which is being used for HIV and other programs, and or new instruments. And we also check the availability of functional biosafety cabinets. We also check infrastructures like UPS, backup generator, water supply, and electricity. And we also check adequacy of rooms which are dedicated for this service, specimen collection area. And we also check availability of critical auxiliary instruments, which are most of the time missed in different laboratories, like microcentrifuges, micropipettes, refrigerators, freezers, vortex, shaker, these all items. And we also check the availability of sufficient manpower that can be easily trained and provide the service. Practice of biosafety and biosecurity, and implementation of laboratory quality management system. So after different assessments and trainings, we have managed to reach at currently 29 laboratories which are providing testing service throughout the nation. So we have at least PCR testing laboratories in main cities of the country. And these laboratories are from human or from Ministry of Health laboratories. We have from animal laboratories, we have from academia, and we have also from different research centers. So as of today, we have 29 functional laboratories, and we have also laboratories which are already ready to provide the service, which are 7, and we have also around 26 laboratories and so 7,597 testing capacity per day, and the other laboratories under verification and the candidate laboratories have capacity around 7,000. And when all those instruments and laboratories become functional, we will have capacity of 15,000 per day. So this is the actual capacity, but if we can include sample pooling system, we can double the capacity, and we can have testing capacity more than this per day. These are the different platforms we are using currently in the country. So it's much, as you can see from the slide, but we don't have another option. So we are using the available technologies in the country, and we have around 10 platforms. So most of them are functional and in use, except from Abbott, we have 20 machines in the country, and we are using 10 of them for COVID testing, integrating with HIV program. And also COVAS 4800. So we have around 8, and 2 of them are in use for COVID testing. So this slide shows how we try to integrate COVID testing with HIV program with our existing instruments. So as I said earlier, we have 20 Abbott M2000 RT systems, and 10 of them are operational. And COVAS, we are using 2 of them. So what we actually did is that we approached both companies to support us in provision of COVID testing. So we repurposed for Abbott's instrument, we repurposed the DNA extraction kits with automated extraction, and we use third-party reagents for amplification and detection for Abbott. And for the COVAS system, we also again negotiated to use third-party reagents, and the company was ready to support us and open up the instruments. So our considerations while we integrate was analysis of the current utilization rate of HIV viral load and AID. So most of the instruments we have for HIV viral load and AID are have potential to be used for other tests, because based on our analysis, up to 50% of the capacities are unutilized, so they can be used for another purposes. And the other thing we considered is that to train more professionals, which can be dedicated for both tests, for HIV program and for COVID testing. And we also instituted 24/7 work schedule to use the full capacity of the instruments without affecting HIV programs. And we also made extra instruments dedicated for COVID testing for HIV. So we dedicated the extra instruments for COVID testing. So this is the trend of weekly testing volume for Ethiopia. So when we started in before, so we started around 3,490 testing per day. So as of today, we reached that 20,508 testing volume per week. So as of today, we have conducted a total of more than 70,000 testing in country. And today alone, we have conducted more than 3,600 testing with those all laboratories. So when we come to quality assurance, so as part of quality assurance, training is one of the areas we are working on. So we provide 3 to 5 days hands-on training in the country, which are ready to provide the service. So after completion of the training, verification, on-site verification is happening in all laboratories. So we 3 days on-site training and run known samples blindly, which are prepared by National Reference Laboratory. On EQA, so materials. So as of last week, 9 laboratories and from most of the laboratories. And we are also working with NICD and HLS to send specimen from our National Reference Laboratory for retesting and confirmation. And we also provide on-site technical support for laboratories in the country. And we have established quality performance indicators, and we are collecting data laboratories and support them based on the information collected. Document developments. So as a country, Ethiopia is developing laboratory testing strategy. So we have the first draft, which is still under review, and we are going to finalize and publish it very soon. And we have also developed laboratory quality assurance document, specimen pooling protocol, specimen management, and result communication protocols. These are the documents which are using to support testing laboratories to be used as a guidance. On specimen transportation, so we have a dedicated specimen transportation system. So most of specimen in Addis are being collected by our institute, and there are also hospitals which are from public and private collecting specimens and transporting to testing sites. And in regions, in states, we are using regional health bureau systems to transport specimen. So our network is all health facilities are linked to nearby PCR testing sites through optimized referral network. So we have lots of experience for HIV program, and we are using the same system for COVID. Few challenges we have. So we have challenges on supply of reagents and consumables. We have inconsistent supply at this time. And since we have expanded laboratories in many areas and we have lockdown issues, it's difficult to reach all sites to provide technical support and other activities. And thank you very much. This is what I have for you.
Thank you, Adesso. And we want to appreciate our two presenters for very informative presentations. And now we'll transition to your questions. as you had shared on the chat box. And we'll start with Dr. Rugola Mutandu. And the question is, what strategies can reduce disruption to HIV and TB testing? Dr. Margaret Adesso.
I'm sorry, can you repeat please the question? I didn't hear well. Thank you.
What strategies can reduce disruption of HIV and TB testing?
Yes, okay, maybe I will start. So as I was saying, one of the key elements is really to assess, first of all, what is your free testing capacity? Because you don't want to overload, so to speak, the testing sites, which are dedicated for TB and taking over. That's an example for COVID testing. So you really need to bring together the needs of, take into consideration the needs for the two diseases. And well, as far as TB and HIV testing, TB and COVID-19 testing are concerned, these are two respiratory diseases. So the requirement for the laboratories are similar. And so that's a way to really, where you can implement and expand quickly, because the requirement are the same for safety, and also even for managing the patient. You have to have infection prevention and control, against respiratory diseases. One of the way also to minimize, when the country can afford, is really to make sure that you have enough staff, human resources in place, and as needed, you might consider increasing the number of shifts. So still taking the example of the gene expert, a gene expert, a 4-module gene expert, maybe you're doing 3 rounds of testing per day, you might increase to 5, but this will make more than an 8-day schedule. Henceforth, you might assign new staff to do maybe a day shift and a night shift. That's an example of ways to really address the testing needs for both diseases and minimizing disruption. So these are the examples I can provide. I don't know, maybe Adisu could provide additional example from the experience of Ethiopia.
Okay, thank you very much. Actually, Dr. Margaret expressed very well. And actually, what we are doing is that most of our laboratories were previously 8 hours laboratories. They were performing only 1 shift, but because of COVID, we have increased our shifts from 1 to 2 or 3. So we are not affecting the HIV program because we dedicate at least 1 shift for HIV program and the other 2 shifts for COVID. We actually have not started the gene expert testing, so we will continue to balance everything. Most of the laboratories in this country are operating only 1 shift during normal periods. So we are going to increase the number of people working in the laboratory, and also we will continue to increase the number of shifts to just balance everything and not affecting any other programs.
Okay. Then we have questions relating to sustainability in regards to commodities. And one from Eric Opio: owing to the global demand for commodities, that is supply chain, vis-a-vis meeting demand for testing across countries, how do we ensure effectiveness in testing? Dr. Margaret?
Yeah, so there are 2 ways to go about that. First of all, we are aiming to have uninterrupted supply chain, and so consumable and reagent being available to the testing lab. And so I would say we have to do our homework, first of all. And what I mean by that is that we need to provide data for accurate forecasting. That's the starting point. So we need to have estimates in place. We need to know how many tests will be performed over which period of time. So as soon as the labs are starting to test, that's the idea. You need to have those performance indicators in place. You need to keep track of the number of tests being performed, And this can inform future procurement. And I was explaining that you have the PACT initiative in place, you have the ACT also by WHO, which are pool procurement system, and they can only function properly if they have accurate data coming to them. If there is no data coming, then the procurement will not be, it can be too much, it can be too little, it will not be accurate, and it will have an impact on supply chain. So that's one aspect of the answer. The second aspect of the answer is that unfortunately, we are now facing the really, how should I say, the shortcomings of our healthcare system, not only our healthcare system, but the way we are functioning, meaning that Africa is dependent on external procurement. Everything is manufactured outside of Africa. It's not only Africa. I think Europe also has also come to terms with that, realizing this, that a lot of diagnostic tests and lab consumables are really being manufactured in East Asia, for example. And so in the current context where everyone is rushing to get access to those, we are not able to compete efficiently. And the way to address this is really, we need to look back, and at one point we hope that pandemic will resolve, but we need to take the lessons and really develop. So there are already initiatives in place, but we need to really increase the capacity on the continent for local manufacturing of lab reagents and of lab consumables. There are already initiatives in place. I think in Kenya, for example, the mask, that's an example. You have Institut Pasteur in Dakar, which is now evaluating a new rapid test that hopefully can be validated. So these are the ideas, that we have capacity locally to produce, henceforth we will be less dependent on external procurement processes. Thanks.
Adisu?
Okay, thank you very much. So as everybody knows, supply shortage is one of the major problems throughout the world, not only in Ethiopia or Africa. To date, actually, we are getting most of our supplies through donations. And as you might all know, we have been getting our supplies through WHO support from Africa CDC, and lately from Alibaba Foundation from China. And we are meeting our need through this all supporters. And we are also getting more donations in the coming few days. But for the future, actually, we are working with WHO, and there is a global consortium which is allocating kits sufficient for countries, and we are actually submitting our requests through that channel. For example, of the next coming months is nearly 200,000 per month. So we are approaching WHO, Global Fund, and other partners, and we are working with them to secure our supply needs. And in terms of local capacity and production of some of the reagents and supplies, actually we are trying to work with technical experts in the country for production of VTM, for example. So we are working on that. We are also working on trying to work on production of molecular grade ethanol. And there are trials in different universities in our center and the research centers. So I hope we will also get some of the products locally in the coming few months. Thank you very much.
Thank you. Then I think there are questions relating to EQA, and I think from the presentation from Ethiopian experience, the proposal to have built capacity, in-country capacity for panel, also I think encouraging the labs to participate in interlab EQA programs would be important, coordinated at national level. And so just to a response to EQA panel availability and access, the chart has been shared where they can be accessed by Gwen Stefan, and they have shared their contact. Then there is also an interest in pooling of samples, COVID samples. So this question has been asked by, it's not identified. Is CDC Africa assessing if pooling samples is an option? And if yes, in which conditions? As access to test kits is a challenge on the continent, even if we can increase the number of labs, we'll still have insufficient capacity. Adisu?
Okay, thank you very much. Regarding EQA, so we couldn't find international provider currently, but our national reference laboratory has produced proficiency testing materials, and we actually distributed to 9 laboratories in the country. And I think the laboratories, all of them has performed well, but we are trying to work with WHO again, and we are also looking for international providers. There have been some international companies contacting us to provide proficiency testing materials, and we will work with them again. And regarding sample pooling, actually, there were some evaluations which were conducted in different labs in Ethiopia. And actually, we have started sample pooling in our national reference laboratories. So we have 4 laboratories in our institutes which are participating in COVID-19 diagnosis. So all of them are using sample pooling. So we evaluated 1 to 4, and we are pooling 4 samples together. And whenever we get positive in pools, we retest 4 of the samples and then report separately. And so this is what we evaluated, and we are actually using currently.
Dr. Margaret, any comment on sample pooling?
Yes, thank you, Kenneth. Yeah, I would advise, because there was a very good presentation on this by Africa CDC and WHO earlier this week, where it was discussed. So if participants want to have more detail, I would advise that they listen to that presentation when it will be put online. But there were 2 considerations. So it's dependent on the country context and the number of positive cases you have. So the positivity rate, because if you have too many positive cases, as we're moving now into the community-based transmission, and you have areas where you have a lot of cases, it might not be so efficient to do sample pooling. But in countries like Ethiopia, it can be efficient. Ghana is also doing sample pooling, but the key message was that the protocol needed also to be validated, as Adisu has explained. So, but really, I refer to the previous presentation earlier this week.
Thank you. Also, we will get responses to other questions on the chat. But for now, I'd like to give Dr. Margaret to have a final comment.
Yes, so thanks a lot, Kenneth. So I hope that you were, the presentation was useful. I would need to highlight and stress, because I also support the countries on the field. Really, the planning stage should not be overlooked. It might seem, especially as we are in an emergency mode, that's that a lot of work to do as we want to move forward quickly. But really, planning is the key step that you need to have in place to be efficient as you expand diagnostics. Otherwise, you might just fall backwards because you've overlooked key items. So that's my message, my key message. Thank you.
Thank you. Adisu, any final comment?
I think let's work together to curb the COVID-19, and we can share countries which can learn from us how they can expand laboratories. And thank you very much for this opportunity to present here.
Thank you. I'd now like to hand it over to Anafi, probably to take us through the closing.
Thank you very much to the presenters, Adisu and Margariti. And also thanks to Kenneth, our moderator today, for the wonderful job. I'd like also to thank everyone who attended. Just one announcement for our country teams. We realize indeed from the concerns that have been coming really with regards to HIV and TB testing in the context of COVID, that they should not be forgotten. And indeed, there are concerns that some numbers for HIV and TB are beginning to go down. So it speaks to our earlier plans on the hashtag campaign. How can we help each other move this? How can we help each other that we don't lose the gains that we've made over the years? So we are now moving ahead with our hashtag campaign. I think almost everything is ready. We are going to be reaching out to you in the next couple of days to see how we can work with the plans that you submitted to us and roll them out. The other last announcement is we will have our next session for the COVID-19 series on Tuesday. And this time we're also touching an interesting subject on masks and how safe they can be. So watch out for the announcement. I think it has already come, but we will send reminders as usual. Till we meet again, thank you and goodbye.